Thank you. My name is Anthony Asare. I'm a PA or a physician assistant from Ghana. I am the president for the Graduate Physician Assistant Association of Ghana, and I'm a founding executive of the Global Association of Clinical Officers and Physician Associates. I'm also the vice president currently for the Global Association of Clinical Officers and Physician Associates of Ghana. I'm a member of the World AMTC network as well. The Ghana PA profession started around 1960 and under the name Health Center Superintendent Assistant, and around 1965 there was a name change to Health Post Assistant, and later the name changed to Medical Assistant in 1968. Then 2010 we changed the name to Physician Assistant. 2013 the Physician Assistant Anesthesia changed the name to Certified Registered Anesthetist, and we still want a name change. The issue was that the profession was introduced on account of more distribution of medical doctors, especially to the remote areas, and that has been the bane of, or the philosophy of emergence of the profession. Even before the introduction of the declaration of the Alma Ata in 1978, physician assistant in Ghana has been part of the health system cadre, and in Ghana forms about 70% of primary workforce, where we describe physician assistant as the backbone of primary health care. We are distributed in all health facilities, from the teaching hospitals down to the health centers, but most of us are found in the health centers and then the district hospital, and we are also the sub-district administrators. We have been working, contributing a lot. We see patients. Let me clarify this thing, that despite our name as physician assistants, since 1960, we have never worked under supervision. There is no legal instrument, there is no law or act of the Parliament of the Republic of Ghana that states that physician assistant has to work under supervision. So we take care of patients within a prescribed job description, prescribed by training and then experience. Most of the challenges that we have faced has been the absorption or the employment of physician assistants who have not been trained by the institution established by the Ministry of Health. There is just one institution that was established in 1968, the College of Health, formerly known as the Rural Health Training School at Kintampo, and that provided a direct employment for the graduate that came. Currently, we have about 14 universities training physician assistants in Ghana, and until recently in 2019, physician assistants had to find their way of employment. So the first thing was employment, but I must say that the government issued a financial clearance and employed about 600 privately trained physician assistants in 2019. One of the things too has been our career progression. We are regulated by the Medical and Dental Council of Ghana, and unfortunately, the Medical and Dental Council of Ghana has not rolled out much programs when it comes to career progression. We introduced in Ghana the postgraduate training in dermatology at the College of Health. Unfortunately, when the program was introduced, the tutors withdrew from it because most were doctors. And I'm talking about the Society of Dermatologists. I don't know, maybe it was a bit politically motivated, and so the program was halted. There is still a program which is a postgraduate program in clinical psychiatry, and that also has some few accreditation problems. But some graduates were actually produced, and the product were referred to as the clinical dermatology officers. About 15 are in practice, and we still have quite a number of clinical psychiatric officers in Ghana working in the psychiatric hospitals, the district hospitals, the regional hospitals, and the sub-district hospitals. So basically, these are the few things when it comes to career progression, where we could mount more of specialties and subspecialties. As I'm talking to you now, we have established postgraduate colleges for nurses, physicians and surgeons, pharmacists. We have that for midwives, and recently there was a postgraduate college established in 2013 in Nigeria for laboratory scientists, and I think they graduated recently. But physician assistant had issues with that, and we are fighting to make so. These are some of the things. We also talk of conditions of service, and I think that is why we are here even as GACOPA, because when it comes to conditions of service with reference to our job and what we do, physician assistants were the salary placements were similar to nurses, which we think our cadre and our job description differs from. So we have these problems and we are dealing with them. And I have always had a definition on the assistant that a physician assistant is not a physician's assistant. The emergence of the profession worldwide, we can see that was not just with shortages of doctors as a personnel who was needed, or professionals needed to assist a doctor in a procedure, but the shortages were to a workforce that was created. I must tell you that not so many people are very comfortable with the term assistant attached to our name, but it's on record historically that Ghana, we have changed our name 6 times, and so the assistant has really not influenced the autonomous practice of physician assistant in Ghana. The name has been there, but there is no legal instrument that mandates the direct supervision of physician assistant by physicians, or that which we have realized from other countries where physician assistant prescriptions are countersigned. We would have wanted a name that will actually define our practice, resonate our training, our relationship with other professionals like physicians, nurses, doctors. Doctors are same as physicians, pharmacists, and co. And so when you say physician assistant to the general public, it seems as if you are assisting a physician, but there is no legal or legislation in Ghana in anywhere or policy that states that we have to assist a physician. If there is no policy, then if we had a name change or a nomenclature modification, that would have done a lot to us. The formation of GACOPA, thank God I happen to be one of the longest founding members of GACOPA during the time that we met Norman Nuagaba when they were building the Bachelors of Clinical Medicine, myself later, and then the President Austin Odo also came in. The idea to have formed GACOPA was that we realized worldwide that we share similar, not only similar training and practice, but challenges when it comes to recognition, standardization, and even being recognized as critical health staff within the health sector was lacking. The idea, as the president of the vice president of GACOPA, what we intended to do was to unite all the cadres worldwide, just like the World Medical Association, so that decisions that we take at the annual conferences and then the quadrennial congress for GACOPA can trickle down the associations through the continental representatives to the association leaders, even down to students. So when we take decisions, it goes to that extent to affect our practice. As the vice president, we look at not just collaborating or bringing together, but we also look at standardizing the curriculum. And so we are incorporating the regulatory bodies. We can't leave them because the regulation of the practice is influenced by legal instruments within each nation. And so we cannot just join as association or as entities. We have to incorporate the regulatory bodies. This is one of the mission too. We also look at making sure that we have a postgraduate training where there is an ascension. We have people who train in specialties, but they are not even recognized as specialists because the establishment are done, while doctors have postgraduate medical colleges where they do residencies and fellowships training. We are allowed to do some master's training as a generalist model in some specialties. Then they will attach your name: clinical officer, orthopedics, physician assistant, cardiology. And I think we have to find a name, and this is one of our vision too. So the vision is standardization, unity, and postgraduate career advancement, and also being recognized by the World Health Organization as critical health staff. It's very unfortunate. I've gone through all the WHO report, our national report in Ghana, and I know that it's similar in other nations, that WHO and others have actually classified certain professionals as critical health staff. These are physicians, nurses, midwives, and pharmacists. That means when it comes to even budgetary allocation, it comes to employment, the people who have been at the center or others who have contributed, they have been described as auxiliary. And I think this thing have to be to be decentralized. This notion has to be decentralized, because physician assistant, we have moved, our relevance have actually transcended or gone beyond just attached to the shortages of medical doctors. Some were piloted programs, but here we are, so many years. Some are even close to 100 years, some 50, 60 years, and we are still here. What it tells you is that we have been the cadre to drive an aspect of a profession, or if there was a cadre to have piloted with medicine, where we talk about professionals who can practice medicine and evaluate the clinical outcomes similar to physicians with shorter training, then it is our cadre. So our relevance is not tied to shortages of medical doctors. Our relevance is attached to we having a shorter training and delivering similar results. And this thing can resonate with career modification even for medical training. In Ghana, doctors were trained for 7 years, then they will undergo 2 years housemanship. It was reduced to 6 years, and now they have introduced the graduate entry medical program. Why not? Because there is so much increase in population, health problems are increasing. We will not finish talking about the recent outbreak of the coronavirus. And how long does it take to train a doctor that long? If statistics and research, peer-reviewed studies have actually revealed that the outcome of clinical practices of clinical officers and physician assistants are similar, then we can then bank our hopes also in training these professionals in this way. It's cost-effective, but vibrant and very intelligent, competent professionals here. So this is what we envisage as GACOPA.